The Parkview Cancer Institute has a unique expertise in esophageal cancer. We have one of the largest volumes and most subspecialized esophageal cancer programs in the Midwest region. We have subspecialized GI medical oncologists, radiation oncologists, cardiothoracic surgeons, and GI researchers. Additionally, our esophageal and GI cancer programs were founded on the backbone of a unique program in interventional endoscopic oncology and surgical endoscopy called the IOSC program. This program, founded in 2013, has produced numerous publications and research studies on both Barrett's esophagus, the precursor to esophageal cancer, and all forms and stages of esophageal cancer. It has focused on new ways of performing minimally invasive surgeries for early esophageal cancer and works hand in hand with medical and radiation oncology along with other surgical services. It incorporates novel endoscopic surgical technologies to enhance early detection, improve staging, the ability to remove, ablate by heat or freeze, or stent and palliate esophageal cancers as well via the new technologies that it incorporates. Working in a multi-specialty GI oncology team, the medical oncologists, radiation oncologists, palliative oncologists, surgical oncology and IOSC specialties, pathology, radiology, and others review each and every case in detail, creating precise treatment plan around the accurate stage and personalized patient medical goals. Our expertise and dedication to the science and patient experience ensures that the best technologies and state-of-the-art research are appropriately deployed while caring for the social and emotional needs for each patient and their family. Esophageal cancer is a form of cancer where cells within the esophagus change and start to grow out of control, forming a cancerous mass. Esophageal cancer accounts for about 1 in every 100 diagnosed cancers in the United States, equal to about 17,000 people being diagnosed each year, making it the 18th most common form of cancer diagnosed. It is important to recognize that esophageal cancer, specifically adenocarcinoma, is on the rise in the United States. It has experienced a 600-fold increase in the number of cases in the last 30 to 40 years. However, among cancer deaths, only 2.5 out of every 100 cancer deaths are attributed to esophageal cancer, equal to approximately 16,000 cancer deaths in 2019. Men have a higher chance of being diagnosed with esophageal cancer than women do, or 14,000 men versus 4,000 women being diagnosed each year. The overall 5-year survival rate for esophageal cancer is approximately 19%, though this varies greatly based upon the extent and stage of the disease. So the 5-year survival rate varies from 5 to 45%. However, between 2007 and 2016, the rates of esophageal cancer diagnosis and deaths have been falling by approximately 1% per year. Keeping track of data like this will help inform decisions about where additional research is needed to better address challenges associated with esophageal cancer. The esophagus is a long muscular tube that connects the mouth and throat to the stomach. It is located within the chest between the lungs and the heart. The upper esophagus contains a valve that regulates food entering the esophagus, while the lower end also contains a valve known as the lower esophageal sphincter, or LES, which regulates food passing into the stomach and prevents acid stomach contents from backing up into the esophagus where it can do harm. The wall of the esophagus is comprised of 4 layers. The mucosa, or the innermost layer, lines the lumen, or the space inside the tube. The next layer is a thin layer of muscle called the muscularis mucosae. The following layer is the submucosa, and then there's the outermost muscle layer. Most esophageal cancers start growing from cells in the mucosa layer. Cells within the wall of the esophagus may begin their abnormal growth as a precancerous or cancerous lesion. The most common form of esophageal cancer in the United States and Europe is esophageal adenocarcinoma. This type of cancer begins in the mucosal gland cells lining the esophagus. The gland cells grow rapidly and take over the lining in a condition known as Barrett's esophagus. These gland cells can then change and form a cancerous adenocarcinoma tumor. This tumor will grow outward through the other layers of the esophageal wall and will typically develop in the lower 2/3 of the esophagus. The second most common form of esophageal cancer in the United States is esophageal squamous cell carcinoma. This develops from the flat cells lining the esophagus known as squamous cells. These cells grow pushing into the lumen and out through the outermost layers of the esophageal wall. This is also the most common form of esophageal cancer outside of the United States and Europe. While this form is not related to Barrett's esophagus, it is more often attributed to alcohol use, tobacco use, and other toxins. While there is no specific cause of esophageal cancer, there are risk factors that increase the likelihood that esophageal cancer may develop. These risk factors include heavy alcohol use, smoking or tobacco use, gastroesophageal reflux disease or GERD, where the stomach acid backs up into the esophagus causing a burning sensation, Barrett's esophagus, which is the repeated exposure of the lower esophagus to stomach acid causing the normal cellular lining to change. Because Barrett's esophagus is an important risk factor, it provides an opportunity for surveillance and endoscopic interventions that can actively prevent the occurrence of esophageal cancer. Parkview has a well-developed program for Barrett's esophagus within our Interventional Oncology and Surgical Endoscopy, or IOSE program. Other risk factors include age, where a person's risk goes up as they age, especially over the age of 55, gender, where men are slightly more likely than women to develop esophageal cancer, diet, obesity, achalasia, which is where the muscles of the lower esophageal sphincter don't relax properly, injury and chemical exposure, HPV infection, also known as human papillomavirus infection, and several inherited diseases such as tylosis and Plummer-Vinson syndrome. Esophageal cancer is often noticed and diagnosed as a result of signs or symptoms it causes. However, the cancer often does not cause symptoms until it is in an advanced stage. These symptoms include pain or difficulty while swallowing, pain in the chest, indigestion and heartburn, unexplained weight loss, and coughing and hoarseness. Though each of these symptoms can be caused by a variety of conditions, it is important to visit your doctor when any of these symptoms occur. Esophageal cancer will most often be discovered due to the signs and symptoms it causes. This will initiate the doctor to perform certain exams and tests to determine if it is esophageal cancer. First, the doctor will take a full medical history and physical exam, which will look for possible signs that may indicate for esophageal cancer. This will be followed up with lab tests and imaging studies such as a barium swallow, which is an X-ray performed while the patient swallows a contrast liquid, allowing for a better view inside of the esophagus. Additionally, a CT or CAT scan, an MRI scan, or a PET scan may be performed. An especially important procedure that allows a doctor to make a positive diagnosis of esophageal cancer is an upper endoscopy. This is a surgical procedure where the doctor inserts an endoscope through the patient's mouth and throat down into the esophagus. The endoscope has a camera on its tip, allowing the doctor to view high-resolution images of the inside of the esophagus. In addition to a detailed upper endoscopy, a second procedure may be performed using a specialized endoscope known as endoscopic ultrasound or EUS. This is an imaging procedure allowing the doctor to view the entire thickness of the esophageal wall using ultrasound imaging. EUS imaging also helps define the stage of the tumor. This is critical in determining the appropriate treatment, and it should be performed by specialized fellowship-trained endoscopists. If a suspected tumor is encountered, a fine needle biopsy technique under ultrasound guidance known as EUS FNB will be used to biopsy the tumor. The tissue sampling obtained during biopsy is then sent to the laboratory for molecular testing and pathologic analysis, where specialized stains are applied to the tissue to help determine its tumor and disease characteristics. The laboratory analysis is used in combination with interpretation by the endoscopist of the EUS images, so to make a definitive diagnosis and create a plan for the patient. During the diagnosis for esophageal cancer and after the diagnostic tests are performed and analyzed, the doctor will determine the stage of development that the cancer has reached. This is known as staging the cancer. Overall staging, which is similar for many cancers, is rated on a scale from 0 to 4, where 0 means the cancer is within the organ, and 1 through 4 designate the amount the cancer has advanced and spread. Other scale used for esophageal cancer is the TNM system, where 3 key pieces of information are determined: the T value for tumor, the N value for nodes, and the M value for metastasis or spreading to distant sites. Each letter will have a value applied to it, which will help determine the clinical stage of the cancer. This information will help the doctor determine how to personalize the patient's surveillance or continued careful observation and treatment. Survival rates are an indication of what percentage of people with cancer will be alive after a certain period of time, often 2 to 5 years, as compared to a person in the overall population. 5-year survival rates are classified for patients with localized cancer where no cancer has spread beyond the esophagus, regional metastatic cancer where the cancer has spread to regional lymph nodes, and distant metastatic cancer where the cancer has spread to distant organs. For localized cancer, the 5-year survival rate is 45%. For regional cancer, it is 24%. And for distant cancer, it is 5%. With the overall 5-year survival rate for esophageal cancer being approximately 19%. After careful analysis of the data collected during the diagnostic stage and a full understanding of the unique characteristics of the individual patient, treatment options will be discussed with the patient, and an individualized plan will be developed. First and foremost, in esophageal cancer, the stage determines the treatment. Important factors must be determined during the staging process. For example, has the tumor spread to regional lymph nodes, or has the depth of the tumor grown beyond a certain point? Since these factors determine the need for preoperative chemotherapy and radiation, which improve outcomes in more advanced stages of esophageal cancer. Therefore, it is important to have the expertise to determine the correct stage and then orient the treatment to the individual patient. So treatment options may include endoscopic treatment, where the doctor uses the endoscope to initiate a variety of treatments, including an endoscopic surgical resection or removal of early cancer through the endoscope using techniques such as endoscopic mucosal resection or endoscopic submucosal dissection, cryoablation, which uses extreme cold freeze therapy to treat Barrett's esophagus or a tumor, radiofrequency ablation, which uses heat energy to treat Barrett's esophagus, endoscopic stenting, used to open an esophagus that has been blocked by tumor, chemotherapy, which is anti-cancer medicine given intravenously or as a pill at various times during treatment to attack cancer cells throughout the body, targeted drug therapy, which is a medicine that targets parts of the cancer more specifically than standard chemotherapy and can be used in association with chemotherapeutic medicine, immunotherapy, which is medicine to help stimulate the body's immune system to attack the cancer cells, radiation therapy, which uses high-energy X-rays focused on some cancers to reduce their size before or after surgery, and esophagectomy surgery, where a surgeon removes the cancer and the surrounding tissue. The type of surgery is dependent upon the stage and location of the cancer. Surgery can be complex and also involve the removal of some or all of the esophagus, removal of lymph nodes, and removal of a portion of the stomach. Esophagectomy requires a high degree of expertise and must be approached with thoughtfulness since it's a major thoracic surgery and permanently alters eating habits and lifestyle. The last treatment option is pain control and management, often done by our specialized palliative oncologists, which is medicine to treat pain associated with esophageal cancer growing and pushing on nerves and causing severe pain. The mainstays of advanced esophageal cancer treatment continue to be chemotherapy, radiation, and surgery, depending on the stage and type of esophageal cancer. While cancers that have developed to a point where they have metastasized to other organs are treated with chemotherapy. Occasionally, other treatment options may be added for metastatic cancer, such as endoscopic treatment, radiation therapy, or other surgical options. The Parkview Cancer Institute is committed to innovative science and clinical research to effectively improve our ability to prevent, diagnose, and treat cancer. We have an array of ongoing clinical trials seeking qualified patients for enrollment. Please visit our website to find out specific information about clinical trials at Parkview. Please note that these are constantly changing and often updated. Therefore, a referral to the Parkview GI Oncology program is crucial so we can best explore primary options and second opinions, which are personalized to each patient. There are many options for the patient that may have esophageal cancer. And at the Parkview Cancer Institute, one of the highest volume centers in the Midwest, we're committed to excellence in pursuit of the best experience, outcomes, and care for every patient.